I'd like to open up the conversation and bring in another perspective from Dr. Murillo. So you're looking at this, you're a cardiologist by training, and practice for quite a number of years, and you're now looking at it from a population point of view, a payer lens point of view. So what are you looking at from a payer perspective around patients with heart failure, around cost, utilization, and how are you looking at these populations?
Yeah, thank you. Thank you for that question, because that essentially is part of the crux of that intersection of so many pathophysiological phenomena in different demographic groups and different comorbidities, sets of patients that ultimately result in what we have today, which is a huge spend in the broad category of heart failure. There's a group of, before I actually answer a little bit more of that question, I sort of wanted to include a group that somehow we don't pay a lot of attention to, but except when you start looking at the analysis. So I went back and looked at the different categories for the past 3 years, looking at what is trending up and what is not trending up and so on. There's one particular group that really caught my attention, and that is what the CMS classifies as hypertension with complications. The two main groups were hypertension with chronic kidney disease and hypertension with heart failure. And that is striking because, think about it, hypertension with complications, what does that mean? That we as a country have not done a good job controlling something as simple as blood pressure. Everybody knows the statistics, 40% of people without blood pressure control, and how many of them undiagnosed. And if you look at also the CDC statistic, you see how the mortality has trending up, and most of that secondary to hypertension and stroke and so on. So that hypertension can also lead to hypertensive heart disease and either reduce ejection fraction or preserve ejection fraction. So I wanted to make sure that we also really look into that specific group, because that tends to be a more younger generation or younger demographics, and talk about, Dr. Nielsen talked about how can we act earlier and start doing something about it. So that's a group where we have a huge, I will argue, a huge opportunity. Now, in terms of how we look at it, so if we look at the 5 top causes of a spend in the cardiovascular environment, you'll find that group that I just mentioned about. You obviously will find the pure CHF or congestive heart failure, so-called, is still on the way we analyze it, but the heart failure group. We find also the chronic kidney disease, one of the biggest areas of the spend. And not surprisingly, we're going to touch on the diabetes group. So that alone, we're talking about 3 out of the 4 highest spend areas in cardiovascular disease. They're there. And this is critical to this conversation.
Jaime, I think you made a really great point, particularly adding this thought about hypertension. Again, observation is that we are, as a society, we're not doing a good job of identifying and treating hypertension, particularly in minority communities. Cleveland has a very large African-American population. Often we see them coming in with, very thick ventricle, with, heart failure. And you realize they've had hypertension for many years, they're middle-aged perhaps. And, to some extent, the horse is out of the barn. And we really probably need to intervene much earlier. And there have been a lot of innovative programs over the years to try to identify, particularly in the African-American community, this problem of hypertension and intervening early enough. I mean, heart failure is a disease that's sometimes best prevented rather than treated.
Correct.
So let me follow up with you just a little bit, Jaime, about how your organization looks at this population and things that you're doing to monitor them, improve treatment, reduce hospitalizations, and so on.
Yes, thank you. As you can imagine, everybody's doing the same around the country. There's some good news from that standpoint. If you look at the pure category of congestive heart failure, out of the top 10 categories, that's the only one where there seems to be some progress that we're making, because every hospital, every healthcare system, every doctor, and obviously health plans are working toward that, try to control that. The key part, I think, moving forward for us to consider successful is what Dr. Nielsen alluded to, which is we need to go beyond just the concept of heart failure and move a little bit more proactively. So we do have quite a few initiatives. Some of them are been more successful when we employ them utilizing the more than 500 ACOs, accountable care organizations, that are affiliated with United Healthcare. And we work with them in terms of, can you proactively treat this person? Can you follow them at the hospital? So the so-called continuum of care, which we have not done a good job in general. Also, when purely previously is still prevalent fee-for-service system where I treat the patient in the hospital, the rest is up to you, and then the primary care doctor, the cardiology outside the hospital takes on. So there's no continuum of care. We're actually making an effort. We're also introducing technology into this concept. So we're using, we recently bought a company called Vivify, and we really actually CHF was the first, or heart failure was the first broad diagnosis that we incorporated into the Vivify concept. As of today, we have enrolled about 20,000 patients in that digital component, and obviously continue to expand and hope that everybody who has a diagnosis of heart failure will be at least in some way digitally touched, and for us to keep in touch with.